Hello, everyone, and welcome. Thank you so much for joining the Uniformed Services chapter of the American Academy of Emergency Medicine for our inaugural webinar, Audition Rotations and Interviews, Key to a Successful Military Emergency Medicine Match. My name is Alex Barbuto. I'm a emergency physician at Walter Reed. So for all the USAAEM folks here, feel free to come on down and visit. I'm joined by just a fantastic panel of friends and colleagues who are here to try to help answer any of your questions as we enter the audition and interview season. So a couple of standard disclaimers. One, these are our views, not the government's. And although many of our panelists sit on the selection board for residency, what is said here is really meant to be advice, not necessarily to reflect actual policy. So if we happen to misspeak, give the wrong date, give the wrong whatever, just a friendly reminder, these are people speaking to try to help you, but we're not representing official policy. None of our speakers have any financial disclosures. We're all here because we want to help you. We want to make sure that your transition into residency goes as smoothly as possible. And so I really appreciate everyone here. A little bit about the Academy of Emergency Medicine. I think it's important for all of our medical students to be either a member of AAEM or ASAP. I think it's important to have a sense of what's going on in our specialty. You know, sometimes in the Department of Defense, we're sort of insulated from some of the things on the outside. But I think these organizations really do a lot for advocacy. And they give you a sense of what the big picture is in our specialty. So for AAEM, the way to do that is the Resident Student Association. They've got some good resources they provide. For students, it's only $40, so pretty cheap. And I think it's worth it. Furthermore, you can join the Uniformed Services chapter, and that's free for both students and residents. We've got some speaking opportunities at our annual conference. We actually had one of our medical students present in Austin this past year. And you just get some good camaraderie, good opportunities, and mentorship with our pretty good sized chapter. So a couple of rules of the road for our panel today. In chatting with all of our panelists, it's okay if you don't want to use rank. We're all pretty casual, but please, you know, doctor, sir, ma'am, it's all appropriate. We're going to be respectful of each other, and I'm sure that won't be an issue. If you have any questions, please either raise your hand or use the chat function, preferably, so that we can help kind of cue those together. Really try to avoid very specific individual questions like, hey, I've got 2 weeks between this rotation and that rotation. Can I come down to yours on a non-ADT? Maybe do this. How do I get a car? Can I stay with one of your residents? Let's try to avoid that stuff. If you have those types of questions, feel free to reach out to our panelists offline. Lastly, this isn't intended to be a recruiting event for our panelists. Just try not to ask them why their program's better than someone else's. That's not great form. But they are going to have an opportunity to kind of introduce themselves and their program. So I already introduced myself. Next up, I would like Dr. Morrison Pons from Naval Medical Center of Portsmouth, if you want to introduce yourself.
Hi, my name is Morrison Ponce. Like Dr. Barber said, I'm the program director at Naval Medical Center Portsmouth. I trained in NADS, and I've been on active duty now for a little, almost a decade, and I'm happy to answer any questions about the Navy or Portsmouth in general.
Dr. Brian and Patrick Murray.
Hi, everybody. I'm Dr. Murray. I'm coming from Wright-Patterson. I'm the new incoming program director at Wright-Patterson. I've been here for about 5 years now, but I trained at BAMC and I did a toxicology fellowship at Emory before coming here. Happy to talk to you all.
Dr. Riddle.
Good evening. It's good to see you all. I'm Mark Riddle. I'm the clerkship director at Darnall Army Medical Center. We're one of the EM MTF programs. We're about an hour north of Austin. I've been the clerkship director for about a dozen years now at Darnall. I look forward to working with you all this year and answering any questions tonight.
I'm just going to throw this out there that Dr. Riddle was a big part of my match into emergency medicine. So Dr. Schmitz.
Yes, thank you, and great to see everyone. And yes, military medicine is a very small world. I am the clerkship director and vice chair of education now at Naval Medical Center San Diego. I'm actually a civilian and spent the last number of years at BAMC, working with the Army and Air Force students, now working with the Navy side, and anxious to help answer any questions I can. Thank you for having me.
Dr. Matlock?
And I'm Aaron Matlock. I'm the interim program director at BAMC, Brooke Army Medical Center. I am former Army civilian now, one of our civilian faculty, and we are a joint Army, Air Force, and now this upcoming year, also a Navy program. We'll have a single Navy spot in addition to our Air Force and Army spots. But happy to be here.
Great. And Dr. Kim?
Good evening, everyone. I'm Dr. Kim. I'm one of the staff physicians at Madigan Army Medical Center. I finished my residency in 2022, so relatively new attending. I'm more than happy to answer any questions tonight.
All right, thank you. I will put this slide back up at the end of our panel, but if anyone wants to take a screenshot or a picture of this, here's contact information for all of our panelists. Really appreciate your time and being willing to answer these questions offline if necessary. I'll leave that up for just a couple more seconds. All right, and with that, we have the next 45 minutes or so, 50 minutes or so to answer any of your questions. Again, if you'd like, you can put them in the chat or raise your hand and ask them out loud. And certainly if you don't have any questions, I've got a pile of stuff ready.
Don't be shy. We know you guys have some questions.
So maybe we can start off with a little warm up. And maybe Dr. Murray, I'll send this one your way. Is it too late to schedule a rotation for this year?
No, I don't believe it's too late to schedule rotation for this year yet. Ideally you do it maybe a little bit earlier, but there are still available slots. If you are interested in Wright-Patterson, we have a website you can go to that has a link to the schedule to apply to come to us. We typically will have 4 civilian spots and 2 USAAEM spots, but we do extend that to 6 and 2 during the summer months.
And I see Dr. Schmitz, because I know that the Navy has a bit of a different answer, I think.
I think it really depends by location. And obviously it varies a little bit year to year, but when I was at BAMC and I will say also at Navy, usually December of your 3rd year, so kind of getting ready for your 4th year is when I start really getting requests. Historically, by January, we were pretty full. This year, I would say for Navy, it was a little bit later just because our GME office was a little bit slower, but by spring, things are pretty set. I do keep a wait list, and occasionally we have people who drop out or something changes with their schedule. And so I think it's worth, reaching out. But for the most part, I would say at this point, we're already kind of into the recruiting season. This is a little late. And for those of you that may be 2nd or 3rd years on the call, I would aim for that December, January timeframe for most places.
That being
Great, I
said,
see
if you do want to visit, we are happy to host you and show you around. And if that would be, we will do anything we can to get folks in a rotation, if at all possible. But if that's not possible at this late stage, then we're happy to host you for a couple of days.
Great, I see it in our comment in the chat really kind of is on theme with this, which is great. So it sounds like for scheduling in advance for the Navy, it seems like much earlier, sometime around December, January is when things start kind of revving up. There may be a little bit more flexibility program to program. So keep that in mind. It may not be too late to reach out, but you should probably be reaching out very soon.
I was just going to make a recommendation that if you can't get a rotation in emergency medicine, I would recommend doing a different rotation that like helps you grow as a physician at San Diego or Portsmouth for the Navy, because then you can come to our didactics, you can meet our residents, you can come shadow, or, you know, like if you wanted to like come one afternoon to like see what the floor is like. And then if that really doesn't work out for you, I would say try to go to Camp Lejeune in North Carolina or to Pendleton in Southern California, because those are the two closest Marine Corps hospitals, or they're Navy hospitals, but on Marine Corps bases closest to the Navy hospitals. And so a lot of our graduates are there. We have a very close working relationship with those faculty. And so I would say those are like your second best options if you can't get to one of the two sites with a EM residency.
Great, thank you.
I would agree with that. And in comment to the question in the chat about already having 3 audition rotations and hearing some advice to kind of pick up some shifts at another place, I personally don't think that's necessary. If you have 2 to 3 letters of recommendation, or what we call the SLOs, that is plenty. And potentially that takes away, you know, some spots for other places. So at least, and I'm interested to see what other faculty on the call think, but I would discourage you from doing that. I think if you already have 3 audition rotations, that's more than enough.
So maybe Dr. Riddle, you can answer this one. Let's say that don't have the opportunity to schedule 3 audition rotations. Maybe there were some problems with getting that many ADTs or non-ADTs. How do you feel about short rotations, you know, the 1 or 2 week rotations or a few shadow shifts?
Yeah, I think that they are can be beneficial. I think you should probably actually have some interest or desire in that program. If you're doing it just to show face and you have no interest or desire to go to that program, it does create work on the other end. Now, maybe you go there and you really enjoy it, and so it does have that benefit. But normally on our side, we can kind of tell who's just checking a box. But that being said, I think for shorter rotations, I don't know that most places will do things as far as an actual rotation for a week, but generally you should be able to set up shadowing anytime between probably 1 day and up to 7 days, something like that, depending on the program, I'm sure. And then we definitely will do 2 week rotations, 3 week rotations, 4 week rotations. And I do think those hold benefit. And I think it allows you to feel the personality of the program, let them to get to know you a little bit, and kind of see the area and find out if it's a fit for you.
Thanks. While we wait for any new questions, any other thoughts on kind of that scheduling side of things from other programs? All right, if not, oh, here we go.
Yeah, I think it's worth it, you know, to learn a little bit about every program. You know, if you're Army, look at all the Army programs, you might be surprised at the different sites. We've had students that rotate with us that initially aren't really that interested, but then they visit the site and they fall in love with it. So I think it's definitely worth it. And as far as scheduling rotations, we all understand that, you know, some schools, although they should be allowing all the military students to rotate through, that might not always be the case. And so you may unfortunately see some limitations on your school end, hopefully not. But as far as when I rotated through, I actually started off in ophthalmology and realized how much I didn't like clinic. And I switched probably like 2 weeks before the match, the lists were due for the programs. And so I actually talked to one of the clerkship directors at Madigan, Dr. Ashworth. I also talked to Dr. Riddle as well over at Darnell, and was able to fit in like a day over at Fort Hood and then a couple days over at Madigan before that was all due. And I was lucky enough for it to work out to me. So you never really know what could happen, but it's worth a shot to reach out to the different sites and see what you can do.
Great, thanks.
Alex, I'd also like to say, just, you know, for those of you who are yet to schedule rotations, I can only speak to our facility, but the GME office is handling a lot of traffic, you know, a lot of emails, you know, I want to rotate, and, you know, every year some things get missed. And I just want to say, if you are having those kind of issues, you're on the ball, you're early, you're trying to get things done, and you're not hearing back from, you know, the office, that you please reach out to the program. You know, if you've got contact for the program, if you want to rotate with us, we want you to rotate with us, and we will help you circumvent any of those kind of things that inevitably pop up just with an office that's handling a lot of traffic all at once. And don't sit silently thinking that we don't want you to rotate. We definitely do. And so just reach out directly if you're having issues.
Great, thanks. Maybe Dr. Schmitz, I'll direct this next question towards you. So for letters of rec, since you briefly brought up the SLOs, does it matter where your letters of rec come from? Obviously, I imagine some of them need to be from emergency physicians, but what are your thoughts on that?
Yeah, I think it's a little different too for military programs versus civilian, but in general, for those of you who may not be familiar with it, it's called the Standardized Letter of Evaluation, which stands for SLO, and the intent of it was to try and to be able to compare apples to apples, because historically it made it really hard if Joe Schmo wrote a letter and we don't really know who that is, of like how meaningful is that. So the SLO, if you've never seen one, basically has a narrative, but it kind of, assesses multiple different things and tries to standardize that evaluation across the board. And I will say that, thank you, Dr. Ponce, for putting that in the chat. That it carries a lot more weight, I think, of a SLO, and I would definitely have at least one, probably two, if you're applying to really any program. In general, my sense on the civilian side is if it is a certain rotation where you really got to know, the clerkship, they can write what's called an O SLO, which is an other SLO. So it's someone outside of emergency medicine. That would be kind of the second best letter. Less helpful is just a sort of random individual letter from someone outside of emergency medicine on the civilian side. I think on the military side, having a letter from someone else is still useful, but I would do it in addition to having at least one or two SLOs as kind of your reference point. But happy to hear from some of the other active duty folks to see how you interpret those and what you would recommend for students as well, since my take on the civilian side might be a little bit different.
Dr. Murray, I saw you raise your hand.
Yeah, so I sit on the committee for the civilian side of our program also, and read through a lot of applications and help determine applicants who are applying, how we rank them. I would say a SLO from a large residency, a large program is going to be kind of like the top tier. A SLO from any residency is going to be kind of next and really good also. If you get a SLO from an ER that doesn't have a residency, that's still valuable to us, it still gives us good information, but it's a little bit of a different SLO since they're not actually ranking. And part of the SLO is actually comparing you to the prior year's kind of applicant pool. And then truthfully, handwritten letters of recommendation are very challenging to read. They're almost always just glowing and overwhelmingly positive, and they provide very little information to the point where I'll kind of skim it at best. So the SLOs are really the most important thing. And, you can get a SLO from a non-EM program that is helpful, but I would say overwhelmingly a SLO from an ER, particularly residency program, is going to be really the best. And what helps us the most to see what your aptitude is for the ER, become an ER physician.
So I might ask kind of a dumb question here. If I rotate, do I just automatically get a SLO?
Great question. No, so the SLOs, you actually have to apply through AAMC for them, and you get a special number along with your AAMC number, and you have to give that to the person who's writing it, which is typically going to be the clerkship director or a committee with the clerkship director. When I was clerkship director, I'd get all those emails to me, and then when I write the SLO, I have a place to where it gets uploaded and actually attached to your file. Without those numbers, there's really no SLO.
Dr. Ponce.
Thank you. We kind of generate a SLO for almost everyone who rotates with us. And the rationale for that is sometimes people say they don't need them and then they want them later. In the Navy, we still have GMO training that some applicants or some residents will do in between internship and residency. And they may rotate with us as a fourth year and come back as an intern, and they may then get out of the Navy and go, match through the civilian program into emergency medicine. So we don't necessarily use those and submit them, but they're kind of like our record keeping. So we will essentially generate a SLO for you, even if you don't ask for one, but you still have to contact us, like Dr. Murray said, and like tell us like what to do with it and like to upload it for you. So we will generate those for you. Because the GME application closes October 15th, you really need to be rotating with us by the end of September, right? So we need a couple weeks at least of your rotation. Sometimes people's rotation will start like October 5th. And, we really only have like 5 days where you're really going to have like one orientation and 2 shifts. A slow based on 2 shifts is like not really helpful. And so you may get communication from us that says, hey, you told us you wanted a slow, but you're not starting until October 10th. We can make you a slow, but you can't use it for the GMESB because honestly, it would probably hurt you. It would certainly be available for your ERAS application if you were like going all in on the civilian match. I don't know if the timing of that kind of like makes sense. So we will generate a slow, but you have to reach back out to us and tell us like what to do with it.
And Alex, on that note, for those of you who are ESAS, I know there's been a push from OSA to tell the students to have 3 letters of evaluations, and people are nervous. They've got their 2 slows, but they'll reach out for a 3rd one from an individual, sometimes just from like Bushmaster or from Gunpowder, any of the exercises from 1st and 2nd year. And I've kind of like explained to OSA that again, you can get a 3rd letter, but having someone who didn't work with you clinically, who like only did some mentoring, a couple times in your 2nd year, it's probably not going to be a very useful letter. Going back to what Dr. Murray was saying, if you have to have a 3rd letter and you only did 2 EM rotations, I think that's where I would reach out to like medicine or surgery, or you do that OSLO, sort of your 3rd letter. But again, I think most places don't necessarily need 3 if you have 2 slows.
Our grading rubric for assigning a score on the civilian side uses only 2 slows to generate it, and a lot of times people only have 1 even sometimes, and we can factor that in. But three doesn't help any more than really 2 does.
All right, I think we'll move on to the next couple of questions in the chat. So Dr. Riddle, there's a question about what are some general advice for interview day? We had a couple of questions submitted ahead of time, just kind of asking, what are program directors looking for on interview day?
Yeah, I was afraid you were going to ask me that because I have very uninspired answers. So, if I'm being honest, I think I know at least all the Army programs, and actually I worked Dr. Ponce on things before, and Dr. Schmitz, and all the programs just want to know who you are and just want to have a nice conversation. And so I don't think there's anybody that's going to be coming down hard or asking unbelievably challenging questions. They just want to get to know who you are. Frequently, there's a lot of nerves, and that's okay. Like we've all been there. We've all sat in that seat. And so I think the best thing you can do for interview day is to be on time and to be in the right uniform and to try to engage with your interviewer in some meaningful discussion and engage with their questions. I guess I would say that I have on occasion had interviewees who were very comfortable or very relaxed, slouching, kind of like, doing kind of weird, very comfortable things. So I would say that it is a professional situation. And so I don't think you need to be rigid, but probably don't need to sit forward in a tripod position, if you will, while you joke with the program director or the clerkship director. So enjoy the conversation. I know that's a hard answer to give and a hard thing to hear, but they just want to know who you are, and they just want to see how you'll fit with the program and what questions that they can answer for you about their program. And so it's not a high stress situation. I know it's kind of impossible to hear, but trust me, I've been doing it a little while.
Thanks, Dr. Riddle. Piece of advice there in the chat. You can ask some of the current residents to help you out, make sure your uniform looks good. While I don't think very many of the interviewers are, critiquing on, with a ruler out there, where's your medal? But I think it does matter to have some military bearing and not look like a total soup sandwich. All right, so back up in the chat. What are some recommendations for students to get the most out of their rotation and kind of understanding the programs? Maybe Dr. Kim, since you were the most recent of our panelists to go through this process, what is some of your advice?
Yeah, so I think what's important is just to continually just try to learn as much as possible. So You'll be picking up your own patients, but if you see a patient that looks interesting that someone else has already started working up, like I don't think there's anyone out there who would like prevent you from seeing that patient. I think there's tons of good learning opportunities to be had. I think if you continue to read, if you see, some sort of diagnosis and you're unfamiliar with it, just continue to learn more and more. Just read as you learn, and just continue to try to get better. There's certain things to focus on, like common chief complaints, chest pain, abdominal pain. These are things that happen all the time that you should be familiar with. And then as far as the different programs go, I think it's good to think about what you want to do as a physician. Is your goal to be more of a community physician in the long term? Are you going to make a career out of the military? No matter what, all the programs are going to prepare you for being a military physician. But there's certain nuances of like more community hospitals in certain programs, and that might expose you to more of the civilian medicine, as opposed to like military medicine itself.
Thanks. One of the questions that I had when I was a rotating student, so I'm on shift, and my senior resident said I could leave early to go to one of the resident social events. Was that a test? Am I supposed to stay on shift, or am I supposed to leave? Maybe Dr. Matlock, how do you want to answer that one?
Yeah, if we invited you to something, we would like you to be able to go, and it's worth clarifying. But if it's we have meet and greets and things like that, and we try to schedule people so that they're able to attend because we want to get to know them. So no, it's definitely not a test. It's worth double checking that, but we're not. It's not an ethical dilemma that there's no hidden curriculum for that. So
I know we had a question in the chat that sort of got answered in the chat, but for everyone, how likely are you to interview with programs that you did not have a chance to rotate with? Is it reasonable to attempt to schedule an interview if we could not rotate at a specific site? And I think certainly with the limited number of opportunities and limited number of programs, it is, I think, important to rotate at every site, or excuse me, interview at every site, even if you don't have a rotation. Now, whether that's in person or virtual is sort of up to you. I will throw this out there to any panelist who wants it. Do you think it matters now if I in person versus virtual? Do you think virtual is gonna keep me back?
I think it can be said that unlike the civilian sector, at least in the military, if you ask for an interview, you will get an interview. So you're not like applying for an interview. So yes, you should feel free to ask any program for an interview. And then to answer your question, OTSG has come out and said that all programs will treat virtual or in person with equal weight regarding the match.
I was just going to add that we've been doing, actually phone interviews for many years, long before any of the virtual stuff started. And it's only because of COVID that we've added a video platform to that. And so I think our faculty and our program are very well accustomed to doing remote interviews. And so I would welcome you to travel and come see the area and meet the residents and come to conference if that is helpful to you. But it does not change your interview with us. And yeah, I would just highlight that as well, that interviews are sort of automatic. You just have to email us and tell us you want an interview, and we will interview you. And there's a whole part of that goes into your application. And so please don't be waiting for us to email you.
Agreed. And the only thing I would add to that is to get on that earlier rather than later. I think, we generally try to do our virtual interviews kind of at the end of the season. But to me, it makes a big difference of someone who reaches out July or August and says, hey, I'm applying to EM. Unfortunately, I'm not going to be able to make it to San Diego to rotate, but I'd still like to interview with your program, and shows interest, versus someone if we stop interviewing on October 15th and someone who reaches out in a panic October 13th, and you can clearly tell they're just trying to check a box by interviewing. I think that puts you in a very different light. So trying to get ahead and schedule those now or over the summertime when you're rotating, I think is generally a good thing. And for most of us, we offer interviews like while you're rotating. So for those who are rotating at a site, you don't have to do a second trip back. It's just something we'll do during your rotation. And then the virtual interviews are an option, for people who are deployed or can't rotate with us. Again, I agree with everything that was said.
Yeah, I think I saw every one of the panelists nodding along as you were saying that. I think all of our programs are very flexible and they want to interview you. They're eager to interview you. They want to find a way to make that happen. So there was a question in the chat that was also answered in the chat about USAAEM students. You have to do your regular clerkship rotations and sometimes double dip as an audition. And Dr. Ponce, noted, just make sure that that's known to your clerkship director, so they're evaluating you in a kind of the proper setting, and how far along in your training you are. All right,
I think for the USAAEM students, that just to clarify, I think most of the people who rotate in the summertime are those that are going into emergency medicine or at least considering emergency medicine. So I think most of the programs are aware of that. We tend to put the USAAEM students who are, doing surgery or going to something else like later in the year. So for us, it's the same rotation, whether it's your audition rotation, your elective, it's the same essentially rotation.
Great, thanks. And also in there is if you're rotating in the hospital but not in EM, but you're in town, that might be a good time to do a rotation, or stopping by for academics. I think some people alluded to that earlier, just to get to know the program a little bit. I know that we've had several of our several residents at Fort Hood who had a lot of their time at Fort Cavazo, excuse me, and were able to kind of see the emergency department even when they weren't on an EM rotation. So that's always an option, especially for the USAAEM students or the occasional civilian programs that have partnerships with our MTFs. All right. So I think we're caught up in the chat, so feel free to keep on posting things there. But maybe I'll send this one to Dr. Murray. What are some red flags that you've seen from students on rotation? Like, what makes it a bad rotation?
One thing that is probably a bad idea is to fight with the faculty about sort of maybe your assessment of the patient. You can always ask, why do you think that? And I'm happy to explain thought process and differential diagnosis, but arguing with residents and faculty it usually is not a good thing. And then, proper military bearing. We've had kind of students come through with pockets down, looking down, saying hey to the prior program director as they walk in on their first day. That's usually a frowned upon sort of performance. Things that I look for that really set you apart as a really good rotator. If you not only can come back with sort of your history and physical, but you've gone that next step, you have your deadly differential and you have a plan of how you want to address that deadly differential. It doesn't have to be perfect. I really don't expect you to do it right yet, but I want you thinking about that next step of how am I going to actually treat this patient to make sure that there isn't something that's going to kill them when they go home again. If you can do that's fantastic, and that looks really good.
I'll add a simple one. This is very much in everyone's control. A red flag for us is if there are things that you need to turn in for your rotation and our chief residents or someone has to keep asking for those things like your CV, your personal statement, we want to see it so we can interview you. I think that, we don't want people like that's very simple. You just, have to get the stuff in on time. But I think for me, it is a red flag because it, tends to portend, that kind of thing carrying over into residency. And so, you just pay attention when you hear from a program you're interested in, if they're asking for something, just get it to them quick. And that goes a long way to communicating your professionalism to the program. So those are things that are important.
Dr. Ponce, any other red flags?
I think, I guess it's the opposite of a red flag maybe, but like someone who seems like they want to be there, right? We all assume you're rotating EM because you want to do EM. So like get engaged, right? If someone says, hey, you want to come see this? Maybe if there's something more interesting to go see, great. But like, go watch. Like I still learn stuff when I watch my residents do procedures, even though, I've done and seen a million of them, right? And so I think get engaged, offer to do stuff, pull the ultrasound in, ask if someone will go scan with you, ask if they'll help you, do a lac repair, do an IV, kind of whatever it is that you think you need for your learning. And so I think that goes a long way. And I think the flip side of that, the red flag is if you're like not really engaged or not really interested, or if it's like, hey, you want to go see that like person? And you're like, nah, I've already seen that today. It's like, okay, well, I still learn from all of my patients. So like, I think you can too. And so that's what we want to see. We want to see students who are engaged, self-starting, really want to learn as much as they can from the patient care experience. And then I just wanted to say something about military bearing because we kind of keep saying that. And I don't think anyone expects you to show up, looking like a gunnery sergeant who's like, squaring corners and sir and mamming everyone. But it is a military setting. And so we've occasionally had students where we've corrected their personal grooming, like shaving or hair and earrings. Scrubs are a uniform. And so our corpsmen are expected to be in uniform. Our nurses are in uniform. Our physicians are. And so if someone corrects you, that's okay, right? Like I get it. Some of you might not have even gone to ODS. You might not even know what I'm talking about right now. And that's okay. But if someone corrects you and then like you show up to the next shift and you're still out of uniform and the next shift, like that sort of stuff, no one expects you to be perfect. But if you call a corpsman by their first name and we say, hey, you really need to call them by their rank, like call them by their rank because we're trying to help you because it does really stand out that you're not like willing to maybe learn or willing to like lean in on, the military medicine side of things.
Thank you. That's, I think, very, very helpful advice.
On that note, I think someone put in the chat, like, can you do it later? And you can certainly do it later. I think most people do it before. I think it puts you at a little bit of a disadvantage in that like people don't have the uniform yet. They don't know a lot of the acronyms. I think they feel maybe a little bit less confident because there's so many things that are foreign to them that they don't know what we're talking about with different acronyms. It's not required, but I think it gives people a little bit of an edge or at least a little bit more confidence coming into the rotation when they've had a little bit of exposure to it, but it is definitely not required. And I think we generally have one or two students each block who have not done it yet. But that's just the feedback they have told me that they felt a little bit lost and it was a little bit of a learning curve to understand some of the military specific things.
Yeah, it's definitely not required, but definitely do it before you're an intern because you can't do it during internship, which means like it delays your orders. It like causes all sorts of issues if you try to do it during training. So please do it before you graduate.
All right, we'll move to the next question there in the chat. Any general advice for preparation before auditions? Any resources that you might want to have ahead of time for your rotation? Yeah, I didn't want to put anybody on the spot.
Specific thing you have to read or do. That we send out a little kind of article on how to give a succinct 3-minute presentation. As emergency physicians, we all have short attention spans, so the presentation is going to be a little bit different than when you're rotating on the CCU and as far as how to present. But I think one of the biggest things to help you succeed is to ask at the beginning of the shift, what are the expectations? I think, and really clarify from the resident or faculty who you're working with, what they're looking for. All of us are a little bit different, right? It depends on the day, how busy it is, what the acuity is in the department. Are we holding a bunch of boarders and we're seeing patients out in the waiting room that day versus we're not? And I think students are used to having a very standardized approach to how they do things. And I think asking up front, what are the expectations? Who am I presenting to today? Do you want the whole spiel or do you want the one-liner? Kind of gets a sense of what they're expecting. And then asking halfway through the shift, like, how am I doing? Is there any feedback on what I can do to do better on this rotation? They'll tell you if you're doing something that's annoying them or if you're doing something great. But better to get that feedback halfway through the shift than at the very end when you can't change it or do anything to make that better. That would be kind of my unsolicited advice.
I think if you're looking for a focused set of reading that you can do prior to your rotation, you can get on SAEM's website. That's the Society for Academic Emergency Medicine. So it's SAEM.org. Or you can just Google CDEM curriculum. I could put down that down in the chat, but that's the clerkship directors in emergency medicine curriculum. They have a M3 and an M4 and a PEDS EM online open access free curriculum that does essentially like a chief complaint based type learning, which I think is very good if you want to try to peruse that some prior to your rotation, so you can have some idea like how would you approach the patient with chest pain, or how would you approach the patient with abdominal pain. It's a very good curriculum and it's free online.
And I've seen some students using that resource on shift, and much to Dr. Murray's point, you go and you see that patient, you take your H&P, but to take it to that next step and have a plan, have a differential, you can go talk to the patient, come back, look at some online resources real quick about what that deadly differential might be and how to differentiate those. So I've seen some people do that successfully. Obviously, you can't spend too much time doing that. We got to keep the department moving, but that's another potential out there. I saw Dr. Matlock unmute for a moment.
Yeah, I was just gonna, I mean, this is a paid service, but I'm a very auditory learner, and I really like to use the spaces in between my studying to learn things. And I'm a huge proponent of podcasts and listening in the car to resources. MRAP is the flagship one. I just looked it up. It costs $245 a year for students, which is not cheap, but the amount of information that is on there, curated, peer reviewed, is this, and a lot of it may not be what you need exactly at the student level, but just immersively, from sort of now on to kind of ingrain yourself with the language, the thought processes of emergency medicine. I think it is a good thing to use, outside of your primary studying, just to hear ER docs talk about emergency medicine. And there are other podcasts that cover things in more basic terms, for more core knowledge, but that's been a huge part of my medical education, and I probably have learned more from that program than any individual person who taught me medicine. So I just, check it out. There's a free trial. I don't work for them, I promise, but everyone listens to it, and it's pretty incredible. So that's just my.
Right, great, thanks. There's a few more resources there that people have posted in the chat, which is wonderful. Dr. Kim?
Oh yeah, I agree with Dr. Matlock. I use that a lot, and I believe the C3 portion of MRAP is free for students. I think it's free for everyone actually. So that might be something to check out.
Great, thanks. All right, so when I'm on shift, how many patients should I be carrying at a time? Like, what's the expectation of me? Maybe Dr. Murray?
Yeah, I mean, I think for a student, for you to be able to really think deeply about the patient, have the time to go in and see the patient, I really don't expect you to carry much more than one patient at a time. If you've been on more than one EM rotation, definitely you can carry two. If you start having more than that, then things can get kind of bogged down a little bit. So the expectation is not for you to kind of move the meat, so to speak. It's really for you to really think deeply and about each of the patients and about what you should be concerned about and how to best work them up.
I think the advice we usually give students is that the first day, like you're just learning how to use the computer. Like if you see just a handful of patients, that is completely fine. But generally, we kind of at week 1, you're seeing one patient at a time. By the second week, you're seeing 2 patients at a time. And after that, halfway through the rotation, when you get into week 3 and 4, most of our students are managing 3 patients at a time. I would say 2 to 3, but some do more than that. It really depends on how sick they are, but many of our patients, if they're getting a CAT scan and they're waiting on the consultant service to come down, like they could be there the entire 8 hours. So it's not a total number per se. It's really how involved and staying busy, right? I think going back to Dr. Ponce's point, like I think someone who appears disinterested or is sitting there checking their email on shift, like that's kind of a red flag for us. I think staying busy and staying active, no matter how many patients that is, you don't want to get, so diluted that you are losing track or forgetting things. I'd much rather you see fewer patients and really own them. But that's kind of the rough guideline that I've been giving students when they rotate with us.
Dr. Ponce?
Oh, no, it's the same thing.
Okay. All right. Any other questions out there? All right, when is a good time to ask for feedback? Maybe Dr. Riddle?
Yes, I think that is a challenging question because the emergency department is frequently chaotic. So at shift change, though, as you're leaving, you should be asking whoever you staffed with the most for feedback from that shift. If you can find an appropriate time for that, if they look like they're crazy busy and things are kind of on fire, it's probably not going to be time for you to get optimal feedback. I do also frequently try to bring up the point that medical education literature always says that teachers feel they give a lot of feedback and students feel like they don't get a lot of feedback. And so recognize that anytime someone you're staffing with alters your plan or makes a suggestion or encourages you to think a different way, that is feedback. And so if you're presenting a patient and you left something off the differential that they thought was at the top of their differential, that is formative feedback for you, whether it was framed that way or not. But the end of the shift is generally when I recommend students take a shift evaluation form, if that's what your rotating site uses, and say, hey, I'd love to talk through this form with you. Can you tell me, I'm happy to wait for a few minutes if now's not a great time, whenever would work well for you, but I'd love to talk through this shift. Here were the patients that we saw together. We saw this one, and this one. Do you have some thoughts on how I did on those, things that I could improve on, and be willing to take growth feedback, because as Dr. Barbuda loves to say, feedback is love. And so if you only want to hear positive things, that doesn't really allow you room for growth.
I was just going to add that sometimes I don't know how what years you guys are in medical school, but usually kind of towards the end of the shift, about an hour beforehand, most teams will kind of round, I call it pre-round rounds. So you can make sure you're tracking on everything before turnover. That's also a great time to ask for feedback, because it's the moment where you kind of are getting set to end the shift. Even giving the shift feedback to the faculty or senior resident at that time and saying hey, maybe after rounds, can we talk about this? I think the last thing is, in addition to being open to receiving the feedback, I think taking a second before you ask for feedback to reflect on the shift, because most people are going to want to ask you, how did it go? And so being able to say, hey, I did a nice job with that one patient where, I knew what to do, and I struggled with my knowledge for this type of patient. I'm going to read more about that. I think, self-reflection is part of getting good feedback as well. So I'd encourage you to do that so you can engage in the feedback session, which should be really a two-way conversation.
And I think the more you can write down who you saw, I think one of the challenges for both residents and faculty, to be honest, is that we're working sometimes with multiple learners. And at the end of a busy shift, I'm trying to remember, who did I see with the medical student? So I usually advise the students just to write down bed 5, GI bleed, bed 2, 86-year-old with chest pain, to kind of help prompt my memory of kind of what went well and what I think they could work on. And it can be hard, but I think we're all expecting that's part of our job, is to give feedback to our learners at the end of the shift. So if it's not, crazy, I think asking for that feedback at the end of the shift kind of prompts us to do your evaluation. And depending on the shift, even if it's just a one-liner halfway through the rotation, how am I doing so far? I think that's helpful. So you're getting that immediate feedback of something that you're doing better or worse, or what to know how to course correct while you're still on shift.
So maybe, Dr. Matlock, do you guys do any, partway through your rotation, maybe 2 weeks in, sit down with the clerkship director or program director? Do you do any sort of midway feedback?
We do. Yeah, we have someone from our clerkship team will schedule a midterm review, and we'll go just see how things are going, and provide, some feedback from their shift evaluations and things like that. And, and frankly, most of it is good and positive, but sometimes there are some things that we think are in the student's benefit to course correct. And so, it's a great opportunity to try to set them up for success. Hey, this is something we've noticed in your feedback that, you could, your documentation is lacking, or, your plans could be a bit more organized. And so that's what I would focus on for the second half. And, historically, we have had people really turn around and really excel in the second half of their rotation based on things like that. And, I will say, talking about feedback in general, it's always nice to get a great job, strong work. Some days you just need that. We all feed off positive, positive feedback, but really the helpful feedback is that which helps you grow. And so, hearing that you're not doing the most awesome job ever it always stings a little bit, but that's really a gift that someone is giving you to try to help you. And I'm speaking from personal experience in that vein. I remember every one of those along my path, and so I would be open to that and recognize that that's for your own growth if you get something to work on. And of course, we're gonna do our best to give that feedback to you constructively. But definitely, I think uh, we owe students the opportunity to course correct and change if there's things that they can improve on. So definitely.
All right, we've got about 5 minutes left. If there's any other good questions out there, feel free to send them in the chat. In the
Dr.
meantime,
Barbuto, if I
Ridley,
can, regarding
yeah.
the mid-cycle feedback, it may be different program to program, and I will intend to do mid-cycle feedback for every student. Recognize that every week we have somewhere between 1 and 5 students coming and 1 and 5 students going, and the programs may not always be able to exactly remember who's mid-cycle at any given time. So I always encourage the students to say, hey, I'm coming up in the middle of my rotation. Can we meet at conference this week for some feedback if it hasn't been brought to you?
Thank you. That's always good advice. It is a busy time for all of our programs. There's a lot of social events going on as well. What are some of the expectations for like outside of shift activity while I'm on my rotation? Maybe Dr. Kim?
Yeah, I think do what you're comfortable with. No one's gonna at Madigan, people like to go on a lot of hikes. Me personally, I am a little bit more lazy, I guess, and I don't like to do too long, strenuous hikes. And so if that's not your cup of tea, you don't necessarily have to do it. But a lot of the outside the department activities are to see how well you get along with the residents in the program. And I think that's a huge thing is, if you're a person that's easy to get along with and get along well with the residency program, and you can show that off shift, then I think that's going to be a big benefit to you.
Our residents do a lot of stuff outside of shift that you'll get invited to during your rotation. And that's like, please go if it interests you and don't go if it doesn't. We have a couple like Navy traditions, like a hail and farewell, which like at the beginning of the year in July in our journal club is the hail and farewell. So it's a requirement, you get time off. It is more of a party type setting. I think there was a prelim question about like, if you drink or you don't drink or you don't, do any of this stuff. So none of them are like, there's no like drinking games. No, it's like hazing you. It's not like frat party or anything. So we have plenty of residents who imbibe in different levels and none at all. And that is like totally acceptable. And no one's counting your drinks. But there will be like fun social events. But like I said, if they're required, they're part of like protected time in our didactics. And all of the rest of the stuff is really just like post-shift fun that, you should feel free to go to if it interests you.
Yeah, I would encourage you to go to the social events. They're not required, but I think it's a good chance for you to get to know the residents. And like generally, is this a community where I'm going to feel at home and where I can kind of collaborate with, but also a chance for them to get to know you better. Right? It's hard to get to know people on a busy shift. And I think that helps with the overall fit and to get that personality. And we were talking before this even started, a number of us met each other when we were medical students or residents, and military medicine is a really small world, and that networking and connections I think is really useful later in your career to start really developing those friendships and relationships in emergency medicine and military medicine.
Can my off-shift behavior affect my application process? I asked that sort of facetiously, but everyone nods vigorously yes. So I think, as with all things, in moderation, have fun, be safe, but really don't make a fool of yourself. Don't hurt somebody else. Everyone's always watching. Everyone's always listening. And I think that's an important aspect of your rotation. While I don't think anyone wants you to feel like you're under the microscope the whole time. That is stressful and sometimes soul crushing. But you do have to be aware that people are going to take note of your actions off shift too. All right, so
that you're a military officer, especially if you're on active duty orders, and there are rules that are bigger than me that apply to you, and don't be the med student who gets in real trouble on rotation, because that is something we cannot save you from. If you miss a shift, please don't miss a shift, but like if you miss a shift, like that's like one level of stuff that we can handle. And anyway, so just a reminder, it goes with the professionalism thing, but it is a different level. You are a military officer, and that will be the rest of your your careers.
I have a quick question.
yes, go for it.
I missed it in the beginning, but if you're a third year student applying for fourth year auditions, I'm currently a second year, but if you're going to be third year and you want to do an audition rotation, when should you reach out again, generally speaking, for a fourth year audition?
Yeah, so there seems to be a little bit of variation between the services. Which branch are you?
U.S. Army.
Okay, sounds like for Navy, the answer is very clearly December, early. It sounds like there's a little bit more flexibility for Army and Air Force, but the answer is probably before March. Dr. Matlock, Dr. Riddle, please correct me if that's inaccurate. Best availability early, though. So we're talking.
Either way, it's first come, first serve. So if everybody else applies in December, there may not be a spot by March. So I think, the sooner the better, I would say, for most branches. It doesn't mean that there won't be a spot. There's definitely more Army spots than there are Navy spots. So it's very likely that in March there may still be some, potential spots that are open. But I think if generally December is going to give you the most options.
Thank you. I guess I'm sorry for stating a basic question here, but what happens if your EM rotation is after March, say like April, May, and you're flirting with the idea of 2 or 3 specialties? Did you guys experience that in your training? And maybe do you shadow a few EM docs before that? I'm curious if anybody has any feedback.
Yeah, I didn't decide I wanted to be an ER doctor until March of my third year. And I emailed Dr. Riddle and got a rotation for a very, very early rotation because they're going to be busy later on in the year. So you're not alone if you're thinking multiple specialties at this point. You're not alone if you're halfway through third year and you're still not sure what you want to do. I might argue that not knowing what you want to do means you're meant for EM because you like a little bit of everything. And I think whatever experience you can get is important. So when you're on pediatrics, go to the ER for the new admissions. When you're on internal medicine, go see those admissions in the ER. Go experience it a little bit when you can. Your med student or your med school might have an opportunity for shadowing or even doing just kind of like single shifts with certain attendings in your department. And that's always an option to get a sense of things. But don't feel bad if you don't know what you want to do yet. That's normal at your stage. There will be a way to find your way in your residency program.
Thank you.
All right, we've got just a couple minutes left. If any of our panelists have some final thoughts.
I was just going to comment about picking your specialty. This is advice someone gave me when I was trying to decide, because I also liked a little bit of everything and I wasn't sure what I was going to do. This vascular surgeon was like, listen, I hate varicose veins, but varicose veins keep the lights on. And I knew I was okay with varicose veins and I could be a vascular surgeon. And I think every specialty has their varicose veins. In EM, I think we probably each have our own different varicose veins. So like whatever you don't like, if you can see that every day, as for 1 or 2 of your patients, like for me, it's like low back pain. Like, you got to be able to do low back pain if you want to be in emergency medicine. It's not just all like sexy chest tubes and intubations. And I think that's true for everything, right? If you want to be a general surgeon, like, you better be okay taking out appies in the middle of the night or something, right? And so I think if you kind of think about it in that way, that really helped me a lot get to the final answer. And so I don't know, I'll pass that on in case it's the varicose veins is helpful to you guys.
We had a really, I think, important question that came up in the chat. And yeah, about signaling your preferences to the residency programs. Because all of the other people are, part of the GME selection board, and they probably aren't allowed to tell you this, I might attempt to field this one, although certainly if any of our panelists want to engage, I think it is perfectly fair to be as transparent as you want. Programs are not supposed to tell you where you are ranked. However, you will find that many do, and I think you should take that with a little bit of a grain of salt. They might be telling multiple people, hey, you're in a position to match. They might be telling more than their match list, you're in a position to match. So I do think you should take it with a little grain of salt if some programs are selling themselves or signaling to you very strongly. I think your transparency is truly up to you. I think it's valuable to let people know if I would be happy there, and you might find yourself happy at multiple programs, and I think that's perfectly fine to say that. Any of our panelists have other thoughts on the signaling question?
Just to give a real quick description, the reason signaling in civilian programs became an issue is that we went from getting 1,000 applications to like 10,000 applications for 10 spots, and everyone was just throwing applications to the wind. And it was really hard to know like who really wants to come to my program versus who is just applying to, 75 emergency medicine residencies. So on the civilian side, they started a couple years ago introducing signaling that you would sort of preference 5 that you really think you want to go to, and that kind of helps them decide who they're going to invite for an interview. That process does not exist in the military, and I would echo very much what Alex just referred to, and I think that be very careful about when a program tells you you're at the top of our rank list. They are not supposed to contact you and say that, but some do, and it kind of puts everyone in a little bit of an awkward position. And I've seen people who got that phone call not match. So I just put that into a lot of perspective when you hear that may or may not be true. But you being transparent, I think is helpful, but definitely not required.
Yeah, and as it has been alluded to many times today, it's a very small world. The program directors talk with one another. They all sit in the same room, and I'm not sure if the GME selection board is virtual or in person, but either a virtual room or an in-person room, and they talk about things. So they'll know. All right, that was a great question, I think, to end on. It's 8 o'clock Eastern time. Thank you all so much. I think this is a great panel. I really hope that you'll consider joining the Uniform Services chapter of AAEM. We hope to do more things like this in the future. I will share our panelists' contact information one more time, and feel free to take that information down. All right, feel free to take this information, take a screenshot if you need to. And again, thank you so much. Feel free to reach out to myself or our panelists if you have any other questions.